Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps. Okay, so Hallux rigidus. I'm going to start this off with this case. This might have been on social media a couple months or a year ago. But a 64-year-old female, active female, has bilateral foot pain and deformity, and has a history of bunions that's been there for years and years. Never really wanted anything done, but it's become more painful. And she's otherwise healthy. She does like playing kind of some recreational pickleball. She likes dancing with her husband. They are the nicest couple in the world. They're my favorite patients. She works as an RN. She's active. So she comes in, and these are her x-rays here. So, bilateral foot x-rays. She says her right hurts worse than her left, but really both of them are bothersome. And if you look at the right, you can see that she's got some arthritis of her big toe. She's got a bunion with an increased 1-2 intermetatarsal angle, history of maybe some stress fractures on the second and third metatarsal, osteophytes and sesamoid uncoverage. This is her lateral of the right foot, a lateral of the left, and then the obligatory obliques. So, Jan and Tom, I'm really curious how you guys are managing this patient. I think there's a lot of things to kind of consider. Are you treating this like a bunion? Are you treating this like arthritis? I guess I didn't really mention it, but if you look at, I'm going to go back to her lateral here, and not so much on the right, but maybe on the left, you get the idea there's some arthritic changes at the TMT joint there. So how are you managing this? Is this a bunion patient? Is this an arthritic patient? What's your thoughts?
I'll just jump in, Jan. Love to hear your thoughts there. Two giant red flags, obviously incredibly nice. Her complication index just jumped at least 10%, right? And then nurse, it's like something bad's going to happen. So, I think always kind of talking about the biggest risk I worry about is recurrence. So that becomes a part of every bunion conversation. You mentioned her age and her activity level, kind of the magnitude of her medial bump there. Be nice to know, how much motion she has and how much painful, symptoms she has with sagittal motion. Some of these are just more stiff. And I'm kind of staring at her sesamoid there on x-ray and wondering if there's something funky going on there. Does she have any plantar pain?
She really didn't have any plantar pain. Her range of motion was not as limited as you would like it to be, I guess you might say.
Yeah.
But and I don't know how you check it, because if you check it with it in this position, it's usually not too painful. But
Right.
when you reduce it and then you try to check range of motion, it gets super stiff. And in this case, you weren't able to really correct it that much. It's fairly rigid deformity, but you can kind of get a little bit straighter.
Yeah.
And how does that make with that scenario, if you can straighten the MTP joint and they become pretty stiff, does that affect how you are going to manage these patients?
Yeah. I guess also depending on their age, right? I'm kind of putting all that together, and everything you've presented, right or wrong, makes me kind of inclined towards MTP fusion as an option. I know that fits in with what we're talking about tonight, but all those parameters, really influence my discussion. And this looks like a salvageable joint on both the AP and the lateral. And I think it comes down to what her sense of preference is. For me, at least in my hands, a bunion of this degree with that amount of incongruence and the arthritic change you've highlighted, there's a risk for failure with the bunion procedure. And I just kind of come at them pretty straight and transparent with that. I kind of throw out numbers that are somewhat arbitrary, but somewhat based on just clinical experience over time. I talk about a 15% risk of recurrence, and certainly the potential for post-operative stiffness, especially with her arthritic change. And then you kind of contrast that maybe from a decision-making standpoint against the high rates of clinical satisfaction that we see with fusion. And I don't know, in my office, a lot of those conversations will end up with a pretty happy and mutual decision towards fusion. How are you approaching that?
Well, I mean, we're talking about MP fusion tonight, so you can probably guess how I'm going to manage this.
Yeah.
But have you ever, it does cross my mind sometimes, especially with some of the success of some of the, minimally invasive or even Lapidus type procedures. Should I be thinking about that in this case? How do you, Jan or Tom, have you ever done that in this particular patient? It's fairly arthritic, admittedly.
No, I'm very like I would say not aggressive with fixing a bunion, but more aggressive with fusions in this type of case. So if they're arthritic and they're having pain like this, I'm after exhausting conservative measures. I could because I want to know what's their major complaint. Is it just the bump? Is it pain? But if it's actually pain and like arthritic pain, then I'm thinking fusion, and I think it's just more reliable in this age population and with the arthritis to get the result that you want.
Yeah,
Okay, I
you
got
guys
two
using,
follow.
I'm sorry, are you using CAT
Go ahead.
scan at all to kind of help with that? Does that influence your decision either at the sesamoid level or kind of look at her cystic change? Does that matter? Maybe in a younger patient, say she's 48, not 64, does that come into play?
I have in a younger patient gotten advanced imaging, yes, because sometimes you get fooled, right? Like the X-rays don't look that bad, but they're having a lot of pain, and then they have like large OCD lesions and so forth. So yes, I have seen that and do that.
Yeah.
With this, I think it's more for me. It sounds like arthritis, and looks more like arthritis.
Yeah.
Um, and then I don't think it's bad to like I have them get injected and so forth to if there's any thought about if they're is this the pain generator, because as people say, like I'm not a great cosmetic surgeon, so if they're just worried about the bump, like I want to make sure that they know what they're getting themselves in. Do they have enough pain to really benefit from a surgery here?
Yeah. Yeah.
Now, if you go towards a fusion, how are you managing the intermetatarsal? Is that a thing?
Um, you know, the times when I'm worried about being unable to correct, the magnitude of her angle or her bump would be with metatarsus adductus. I really don't see that here. Kind of the drift of those lesser metatarsals towards the first, they seem pretty neutral to me. And again, on exam, trying to assess the correctability of the joint in the office, before you get to the OR. But she's got enough metatarsal head and structure there where I think you could really correct that IM angle, get a nice neutral hallux, and do some medial, exhaustectomy if you had to, particularly if you're going to do it open. I think, you guys know I'm a little bent towards MIS, rightly or wrongly. And that's for me kind of a frontier and an algorithm I'm trying to explore. I think if she's nicely correctable in the office and I get a sense that I can really, compress the width of her forefoot, then I'm probably going to do this through an MIS approach. But a more rigid deformity, that's definitely part of my algorithm where I feel less confident in my ability to really give her the cosmetic correction that Jan was talking about without opening that up.
There was a question in the chat, Tom. If you say if someone thinks this joint is salvageable, what pushes you over the edge, maybe to like say, okay, no, they need a fusion? Would it be advanced imaging? Would it be something else, or even the opposite? Would be like, hey, yeah, they want to retain some motion. Maybe they're a dancer. Would you try to salvage this at all costs? I don't know for Nick or
well, I wouldn't say at all costs, but definitely having that conversation about what the patient's expecting. As you guys know, the kind of community, I guess, acceptance of fusion as an idea that sounds like a good idea, is really low. A lot of times, as soon as you say the word, you can kind of read their face, and so I never want to sell that as an option against someone who's persuaded against it. We can talk about recurrence, we can talk about stiffness, but I think if on exam, based on range of motion, based on kind of reducibility of the joint, if they're inclined against fusion and towards preservation, and we've had a good conversation around that. Again, there's nothing about this X-ray that makes me feel like that's never going to work. I think you could get great translation of that metatarsal head with an MIS transverse osteotomy. I think you could get reasonable reduction of the sesamoid. Again, that sesamoid starts to look a little funny to me, and so I think if the patient's really inclined towards preservation, towards bunion correction as opposed to fusion, I might use a CAT scan in this setting to just again kind of have a transparent conversation with the patient. Hey, these are some things that you might not like about bunion correction. But yeah, that's it. I think you could go either way with this, and I would always follow kind of the patient's preference in that conversation.
All
Well,
right, what you do here?
yeah. So in this case, it's a fusion night. So, these are all the things, kind of treatment options I put out there. And we did have that kind of discussion, but after talking to her, and I think saw her a couple of times, I felt like the most predictable option was a fusion. So we did an open fusion. Now, this is not her foot. There's a lot more osteophytes. I'm just using this as an example of another fusion case we did, where showing kind of what a standard open approach would look like. And I went back and found Dr. Coughlin's technique article from JBJS. I think this is from 2003, 2004. And if you're looking for some technique, 2004, September of 2004, some good technique tips for MTP joint hallux rigidus resection and MP joint fusion. This is a great article to go find. This techniques and out of JBJS. And Dr. Coughlin really wrote probably one of the more monumental quoted papers, I would say, on hallux rigidus. And that's kind of what I grew up on in terms of knowing when you talk about the literature. So this, I use cup and cone reamers. I'm just going to talk through kind of an open approach, a dorsal approach adjacent to the EHL, cup and cone reamers, prep the joint, take off any osteophytes. For a long time, I used a plate kind of like this, a very standard, locking mini 2.7 T plate, but certainly multiple options out there commercially available with all sorts of angles. But I think, this raised some question for me in terms of talking about technique and what you're seeing in the operating room when we're looking at position. She has a valgus deformity, she's got some pronation, but I'd love to hear how you guys position the toe. This is out of Dr. Coughlin's, and I think this the picture on the left is just kind of showing how you check your sagittal alignment. But what are you guys looking at in the OR to judge alignment? And there's kind of three things I look at, but I'll be curious what you're all looking at as you do these fusions.
Yeah, that flat plate image is beautiful, because that's really the golden pathway in the OR, at least for me. And I think this, in contrast, that image, kind of schematic image bottom right of that maybe 20-degree plate or 15-degree plate really makes me nervous. It's in every article we read about this, and yet I know that if I put more than a neutral 0-degree plate on, I'm really worried about leaving that patient too far up. So I don't know what lies more, C-arm or those antiquated schematics that we read about MTP fusion. I think you just got to really pay attention, as you guys know, to that clinical alignment using that flat plate. I would never leave the OR without checking it against a flat plate. And it is subtle, right? Don't you think that, how many times have you got it, pinned it, looked at it, and had to kind of back out a provisional pin and repin it and reset it? That's a routine part of my fusions, whether I'm doing it open or MIS. And so easy to get that, not quite right. And I think that makes all the difference in terms of patient satisfaction post-op.
Well, I know that, my reps now have, they got the plate off. They make sure they don't put that, on the back table somewhere. They keep it there, or they keep it on the back table because I like to use that plate both clinically and now even just a lot of times when I'm getting x-rays, whether it's like a midfoot case or deformity case, is getting a kind of a simulated weight bearing x-ray as well to be able to see that. I totally agree. You back it out and you rotate, correct rotation, and it's and you focus a lot on that. What do you think? What do you guys do in terms of your varus valgus? I tend to make mine a little bit less, probably more 10 to 15 as opposed to 20 degrees of valgus. That seems like a lot, because if they hit the second toe, they're going to rub it or irritate there a little bit. But what are you looking for in terms of your alignment there?
Yeah, I'm not measuring. Maybe I should be. Maybe that's an error. But for the alignment, but I look clinically. I look at their other foot and then look at that foot and try to, I guess, say that's the cosmetic part for me too. And I have almost like everybody in the room look, be like, does this look good? Like, I feel like I'm on the show Botched, right? Like on one of those cable television shows. I even have the anesthesiologist. I was like, hey, do you think this foot looks good?
Absolutely. Yeah.
And because I think that's what they see, right? And if they see that the toe is wrong, right? Like, and it's not like a bunion. So I hate bunions. Like I like fusions. I put it where I want it to go, and that's where hopefully it stays. And so that you only have one chance, because a bunion, there's some flexibility and so forth. It may shift. Hopefully you don't have recurrence with a fusion, right? I mean, it should be fused. So yeah, I do it more cosmetically and just look at the other foot and just say like, yeah, this foot looks normal.
Jan, you on that point, you posted, we were talking before we started about your LinkedIn post from today, and where you have adjacent toe drift. I think you posted a Hallux varus case today, where maybe fusion is going to be the answer, but when the second toe follows that, right, kind of limiting your ability to maybe get as neutral a correction without starting to run into the adjacent toe. And the same can be true, probably more common, right, with a Hallux valgus, and maybe chronically the lesser toes are drifted also in the valgus. The whole thing's kind of windswept.
Yeah.
And it's really easy to get the peace sign, right? If you kind of put your Hallux exactly where you want it. So it's complex math as you try to figure them out preoperatively. I'll frequently kind of tell people about that, and we'll spend a lot of time trying to figure out, is their second toe at all symptomatic? Do they have any metatarsalgia? Because a lot of times I'll in an effort to get the big toe where I think I want it, if they've got some adjacent forefoot deformity, I'll fix the second and third hammer toes first, maybe pin that in place if that's the technique we're using to kind of get a good set point or reference point to build my Hallux around.
Yeah.
Yeah.
I will say that the minimally invasive distal metatarsal osteotomies has made that decision, I think, a whole lot easier now. Whereas before it was hemming, and do I really want to do a while? Do I really? Because I never liked the way they look, and then they're stiff, and it was such a chore. So you're trying to talk yourself out of doing anything. Now it's not. It's kind of I won't say it's a second thought, but it's amazing how much better that goes, and you can still control a lot of things with that. So that's been actually a really nice thing about it. What about rotation? Talk to me about like rotation. This patient was in some valgus, so there's some pronation of the big toe. How are you assessing that? Is that just looking at the nail and kind of guessing it, or not guessing, but judging it based off that, or are you looking at anything else?
Yeah, clinically, the nail certainly. Also, kind of reading their callus pattern preoperatively. Is that part of what bothers them? And if so, really focusing on making sure as you check it against the flat plate that your callus has been derotated and that you're really on the pulp of the toe. Nick, I know you posted kind of a review commentary on an article that was looking at flat cut MTP preparation, and I'm almost a little squeamish to admit it, but I turned to flat cut a fair amount, particularly in a big rigid deformity, particularly if we're going to do some adjacent lesser metatarsal shortening, in a rheumatoid foot. That for me has been really effective. I think more easy to get a predictable derotation a little clunkier to get, you know, the right flat cut opposition in terms of your dorsiflexion, plantar flexion set of the big toe, but really powerful. Sometimes able with a flat cut, then if they've got a big IM angle or some rigidity to their midfoot, you know, you can kind of translate the hallux laterally, you know, through that flat cut, and still have plenty of bone for good flat cut opposition. For plate fixation, you can then do a medial exostectomy to kind of take off the uncovered portion of your metatarsal. Are you guys doing flat cut at all, or I feel kind of antiquated as I say that, maybe?
No, as you say it, you know, it's I haven't done that many, but I think you're onto something there. I think that's right, and especially with the big deformities, the big rigid deformities, because it is, you have to shorten them a bit in order to get them brought around a lot of times, or you're really, you know, struggling. And then sometimes you have more problems with rotation because, you know, that you kind of lose that part of it. So I think you're onto something there. I think that's a really good tip, you know, to kind of keep in the back of your mind that if you have that kind of deformity, not to be scared to go to a flat cut. Jan, do you use flat cuts?
You know, I have in some of the more of the revisions,
Mm-hmm.
you know, but you know, especially if I'm like adding bone graft or something, if I'm taking like iliac crest or, you know, something more structural, then I've done flat cuts because it's easier to deal with. But primarily I've not, but you know, I don't do many of these, right? This is so I'm fairly standard. I usually just use like, I only use the cup and cone, I only use it on one side, and then I proximally, and then distally I'll just scrape the cartilage off, because, you know, I've seen that, you know, by myself as well as working with like residents and so forth, fractures occurring with the cup and cone reamer,
For
and then
sure.
you fracture the
Yep.
distal phalanx.
Yep.
Like,
That's miserable.
it's just miserable. It's just like an added, you know, thing that you don't really need in the
Yeah.
OR. So that's why, like, I use it just on, you know, proximally use those reamers, and then
Yeah.
the opposite side, just scrape it just like you would, you know, prep for another fusion. I think
Yeah.
it's just safer in my hands and in residents' hands, because you're less likely to break things.
Yeah. That was the thing from Turner. Remember? He'd always do that.
Oh, I don't
Get the
remember that,
confusion. Yeah.
but
Yeah. And
he learned.
he'd go medial too. He'd go medial. And so you were struggling to get there. And then it was such a breath. I thought it was such a breath of fresh air to go dorsal medial. But so in the interest of time, you know, we did a fusion. This is kind of where we ended up. I'll show our final x-rays. I'm always amazed how much you correct the 1-2 intermetatarsal angle once you do the fusion. And she did well. I think she actually went on to have her other side done eventually as well. And like I said,
Despite being
such,
nice and despite being a nurse, huh?
yeah,
Yeah.
despite all of that, she
Remarkable.
had no non. You thought for sure I was going to a non-uni. She did have a
Yeah,
stress
right.
fracture. Actually, she developed on her right side, like in like the third or fourth metatarsal at some point. Uh, but overall, did pretty well.